I'm the president of the Pan-Arab Critical Care Medicine Society. It's my pleasure on my behalf and behalf of the board members of the Pan-Arab Society to welcome you all in our 20th conference. And first, I would like really to appreciate and thank Dr. Kifaya, Dr. Abdurrahman, and Dr. Salah and their team for the great effort you put to make the conference so successful. We really appreciate. We are, of course, under the umbrella of the 12th Kuwait Critical Care Conference. And also, it's my pleasure to present my friend, old colleague, Professor Jorge Hidalgo, the president of the World Federation. It's our honor to have you here and have the support and affiliation of the World Federation to our conference. Welcome in Kuwait, our second country here, and I wish you all that you enjoy and get the best out of this conference to carry out our knowledge. Thank you very much, Professor. Thank you very much again, Dr. Abdurrahman, Dr. Kifaya, and Dr. Saleh. And thanks to everybody for attending, and I hope you enjoy and get the benefit. Thank you very much. Thank you.
Thank you, Professor Hussein. And we will start the session this morning, the year in review. And we will have a good speakers this morning. And it's my honor to introduce Professor Alison Fox, who is a professor of medicine at McMaster University and critical care medicine specialist, head of the Services for Critical Care Response Team, and director of medical education at Hamilton Health Science. And also, Alison is the chair of the World Congress that is going to be held in Vancouver. If you have any questions regarding the Vancouver meeting, please, Alison. Alison, welcome.
Good morning, everyone. Trying to do a year of sepsis in 20 minutes, it may be a bit of a rush course, and if I've missed a particular paper, I apologize. I have some conflicts. I run the National Research Network and funded by the federal government to do that, and I also receive funds from my university and my hospital for my chair. What I'm going to try and do over the next 20 minutes is really set a broad agenda of the literature that's been published and some of the public health and public policy initiatives that have been taking place over the past year. Really evaluate whether we can improve some things around coding for those of us who still rely on coding, and talk about the impact, the trials that are coming, and because I started life as a bench scientist, I'm going to throw a little animal work in as well, and really summarize some of the impact of sepsis awareness. I'm going to start with this framework because I think it's important to frame what's been coming out of the Surviving Sepsis campaign and what that group has set as a research priority. This is sort of a little Delphi process where the research group out of there set some objectives, both for clinical and basic science priorities. That was published in January, the beginning of 2024. I will say we have progressed in some of them, but not all of them in terms of what we're trying to set as topics. But it's clear from the conclusions of this process that existing evidence requires collaboration. And as we go through these studies, I think I want to set the theme of how we can better collaborate to set some of these topics. I'm going to start with one of our papers that literally was just published in the last paper version of critical care medicine. This is from our group talking about a new ICD-10 algorithm. Our Canadian group has really been working on expanding because those of us who live in coding as part of our identification of sepsis have struggled a little bit with characterizing this. This is based on a large population out of one city of nearly 1 million people in Canada. And I think there's a couple of take-home messages from this. The current coding as it sits within ICD-10, and many of us have not moved to ICD-11, is limited. But when you look at this combination of infection and organ dysfunction, you probably pick up a spectrum of sepsis, that may require an ICU and many that don't. But the mortality still remains high, at least in this cohort, across a Canadian healthcare system, and many of them require organ support. I think this is the next big take-home message, that we know that globally and within the WHO, there's been a huge emphasis on antimicrobial resistance. And I want to highlight this part that really says, since Christina Rudd published the initial burden of sepsis globally, that in fact the deaths have gone from 11 million to 13 million, according to the Global Burden of Disease report. But more frightening is the impact and the potential impact of antimicrobial resistance, irrespective of where you are in the world, and how that's going to impact our ability to manage sepsis as we have increasing antimicrobial resistance. So the attributable versus the impact of that disease, and you can see by the larger colors, it's going to affect our aging population perhaps more. The graph on the far, your right-hand side over there, really talks about the fact since 1990, when antimicrobial resistance primarily affected the youngest of our population, it's now affecting our elderly. The next thing that we're learning is sepsis remains amongst the highest costs in our healthcare system. And for those like me who live in a government-funded healthcare system where we're constantly complaining about not enough resources, I think if we have any impact, it's that early recognition to decrease the costs of sepsis in the healthcare system. This is another paper that just came out from our network, in which Callie and the team looked at patients in a large database, 40% of the Canadian population, over a period, and demonstrated that our survivors of sepsis become not the top 10%, but the top 1 to 5% of healthcare users in our system over the next 90 days if they survive their hospital stay. Massive cost to the healthcare system. And previous data that we showed had said that already cost us pre-pandemic $1 billion Canadian dollars a year. So it's a massive cost to the system. The second paper talks about what programs we can do within hospitals to reduce this. And this is from Sean Bagshaw, I don't know if Sean's in the audience, and his group in Edmonton, where they looked at antimicrobial stewardship programs, the use of procalcitonin, and BD's new technology in terms of BioFire, and what was the cost of that? Did it add to healthcare system cost? And was it going to be beneficial to the entire system? And this economic says there's a small difference in applying these techniques to the cost. It may not reduce it, but it doesn't add an excessive amount of cost. So thinking about antimicrobial stewardship in this era of increasing antimicrobial resistance. And I think there's going to be a theme of antibiotics coming through this. I wanted to include some qualitative data as well. Probably don't have time to read all of the quotes, but I liked this paper from the Danish group, just looking at a small cohort of people. Importantly, only one of these patients had an ICU journey for their sepsis, and yet they all experienced changes in their life course in the 3 to 6 months after they were admitted to hospital. They all still had cognitive impairment, and they were all, despite not having an ICU journey, left with anxiety. So we talk about our ICU journey, but we shouldn't neglect that the impact of sepsis on even ward-level patients can be significant. Digital alerts and the use of digital alerts are coming as we build electronic healthcare systems in most of our hospitals now, and some of us have turned those on and some of them haven't turned them on. But what's the impact on the healthcare team when we add those digital alerts? This patient has sepsis, give your antibiotics in an hour, you haven't done the right blood work, whatever that happens to be in that digital alert system. And this qualitative study really looked at 4 things as an impact. Does it support our decision making? Maybe not when the emergency department's quiet or the response team's not too busy, but when you're overwhelmed, that alert might remind you that you've got a patient you need to think about. Improving the alerts and how we introduce them into a healthcare system is important. And context matters. The uses of alerts may not be appropriate or needed for everybody, but we have to think about the context of what's happening at the time. More quotes here in terms of how it helps maybe junior faculty, maybe more than senior faculty. We talk a lot about AI, and I tried to find an overarching review. This is a scoping review of all of the machine learning techniques. I'm going to emphasize 2 things in this paper. The first is 40% of these studies were done on one group of ICU patients from Boston area. The rest were private databases, and none of these came from eMERGE alerts. We've got a big problem of what we're feeding into our AI models to make decisions. The second point that I want to emphasize in here is all of these machine learning tools still put respiratory rate as one of the most important vital signs for recognizing deteriorating patients as part of sepsis. And yet, I don't think anybody in this audience would deny the fact that it's also our most poorly measured vital sign. And we don't do a good job, and if anybody can figure out why and how we could measure respiratory rate better, we might improve some of these machine learning tools. The other thing to show in the graph is the AUCs are all over the map, right? Timing matters of when you're going to use these alert systems. Some of them are very poor, some of them may be a little better, but the data's not well integrated. Most of our evidence from SEP3 or whatever we're going to talk about came from wealthy countries. And I highlight this paper from Sheila and her group talking about what we need to do in resource-limited settings. The graphics are fantastic in here, but the big take-home message is some of the Surviving Sepsis campaign will apply, some of it will not apply. And the resources in terms of oxygen, the resources in terms of vasopressors, the resources in terms of fluids, and using not the technology that we have, but your clinical exam, your cap refill may be equally important to thinking about the resources that you have in those countries to support sepsis in resource-limited countries. Hot off the press, Yassine's paper in terms of, I think, Yassine, you've proven that QSOFA can work. You know, when SEP3 was published, oh, we put QSOFA in there, but don't use it as a screening tool. And Yassine has gratefully shown in this very elegant study that was just published in JAMA that in fact, you might be able to use QSOFA. Is it best? Maybe not, but you can certainly use it and improve early recognition of sepsis. So beautiful paper to show that it favored screening with QSOFA versus no screening whatsoever. I'm going to flip to one of those things that came out of that goal from the Surviving Sepsis campaign, and it was really to think about the translational gap that we've had for many years. This is from our own research lab. We have a bad problem in the animal side of using healthy young male mice. This study showed 2 things. First of all, there's a difference in the physiological response between aged and young mice. Hey, we knew that in humans anyway. But the other thing that it showed is a sex difference in this as well. So we're starting to build some data about differences in animal models. In particular, we've now switched within Canada in our national preclinical sepsis platform to using different intra-abdominal sepsis model than the traditional cecal ligation and perforation, and doing it in a multi-center style with standardized protocols. The other thing is the breeders of research mice have actually gone away from very inbred mice to outbred mice. And I liked this study for two reasons. Again, sex differences, we need to study it better. This was a juvenile influenza model, but clearly showed different immunological responses between young female mice and young male mice in an outbred model of mice. So asking and addressing some of those questions that Surviving Sepsis campaign said. Okay? Different pro-inflammatory kinds, the young male mice tended to go into the immunosuppressed, and maybe that's why we have more men with sepsis in our ICUs. And finally, this one, in terms of using techniques that we use for clinical medicine, this is a scoping systematic review of all of the animal studies that have done about mesenchymal stem cells. We're about to start phase 2 trials in Canada with these mesenchymal stem cells, but we've gone back to the bench to look at this work beforehand and have been able to demonstrate that there is a benefit of using these in multiple mouse models, as well as potentially in humans. Let's see. Diagnostic tools. If there's anything we're missing in sepsis, it's a diagnostic tool. We focus too much on looking once the horse is already out of the barn, primarily in the ICU. This is work from colleagues in Canada looking not in Canadian population, but in an African population of children, and then validating it in a North American population using genomic analysis. And the basic principle of all of this is they were able to pick up early neonatal sepsis using only 4 genomic signals that appeared when that child was born before they even got sepsis. They were already at risk. So I think we're getting closer. I don't want to throw all of the proteins and everything else, but if we can develop rapid genomic tests, we might be able to predict it earlier. I think we finally put vitamin C to rest. This is work that we've done out of the Lovett trial. Looking again, how many more phenotypes are we going to get? But Manu and our group, they looked using rapid protein analysis, able to identify 3 phenotypes. All 3 phenotypes actually showed harm with vitamin C. Importantly, in those that did not receive corticosteroids, there was actually a benefit for 2 of the phenotypes compared to not. So some of those pro-inflammatory steroids work, one of them didn't. Similar to what Carol and Calfee and others have done with ARDS. Back and forth. Beta blockers, no beta blockers, beta blockers, no beta blockers. This trial, the Lancet trial, basically showed that the use of beta blockers, while it lovely reduced heart rate, may have actually been harmful if you had normal sinus tachycardia, and the only potential benefit was in atrial fibrillation. Okay? So a precision approach to beta blockers, yes, it may be good for catechols, may blunt the immune response, but it's not for everybody. BLING-3 has come out. BLING-3, an important trial about continuous versus intermittent infusion of beta blockers. The point estimate was just on the edge with the confidence intervals, so they couldn't say for sure. But when you add it into the systematic review that came out after this, I think our practice needs to change with our beta-lactams, because whether you used a Bayesian, 2 different Bayesian approaches, 2 different frequentist approaches, beta-lactams by continuous infusion are the way to go with our infusions now. So I think we've knocked that one down. The BALANCE trial, again from our Canadian group, in combination with our Australian colleagues. Have you changed your practice already based on the BALANCE trial? Who's changed their practice based on BALANCE? No more 14 days of antibiotics for gram-negatives, please, for bacteremia. Remember, this doesn't apply for Staph aureus. We excluded Staph aureus out of the BALANCE trial. But for most other bacteremias, you can use 7 days only. It's non-inferior. The work by Haley Prescott and Bob Preston in Michigan came out of a natural experiment where they lost access to piperacillin and tazobactam for a period of time. And what they were able to show is when they only had cefepime, now I don't have cefepime in Canada, but I've got a couple of other antibiotics that don't have it, they were actually able to show a benefit in mortality. And this most recent publication that just came out in terms of the potential modeling of this would show that if you kill the anaerobes when you don't need to kill the anaerobes, you may actually increase mortality by 20%, right? We need those healthy anaerobes in our gut. And so unless you've got a perf viscerus or an anaerobic empyema, maybe we should be avoiding anaerobic coverage. Let's get rid of the piptazo for that difficult community-acquired pneumonia and rethink that. The last bit of all of this is talking about beyond norepinephrine. Yes, we rely on norepinephrine and epinephrine as our first-line pressor, but in this large systematic review looking at all of the non-cholinergic vasopressors, the one that really came out was methylene blue. There's a bit of a signal, but it sits right on the confidence limit, the line of neutrality for vasopressin. And we subsequently published a methylene blue systematic review that favored, with small studies only, the use of methylene blue for vasogenic for septic shock. And so I think we need more trials. About to start some pilot work in Canada again to bring methylene blue back, maybe at a volume that we might use it as an adjunct agent. Importantly, in those systematic reviews, it shortened the time in shock, it shortened times by using an adjunct agent as your vasopressor. I want to finish up with talking, this is a lot of research that's happened in the last year, but in the background has been a lot of advocacy and work at the WHO, all of the things that are happening with World Sepsis Day and the Global Sepsis Alliance and all of the alliances. I don't think we're going to change the public perception unless we change policy. Most of us know that we don't make big changes with science alone. We have to change policy to have an impact. And so the GSA, I'm also on that board, have launched an agenda for 2024, the launch of Global 2030. There's my 5 years that I talked about earlier this morning. And finally, getting governments on board. I'm unfortunately saying that in Canada, I'm one of the few G7 countries that doesn't have a national action plan. When I asked my government officials about it, it's only partly that the WHO has made it a directive since 2017, but it doesn't have a political willpower behind it in certain countries. And so not every country has a national action plan, but maybe changing that landscape will be important, okay? We've just now got the Americas, all of the Caribbean countries in a coordinated response. Australia, David talked about reducing their in-ICU mortality for sepsis down to 8%. It's because of their national action plan that's been there since 2000 and a coordinated effort for that to be able to do it. So look at what the Aussies have been doing. So in conclusion, 2024 was a year with broad research and health policy progress. We may need to think broader about coding sepsis while awaiting ICD-11. We're going to have to test ICD-11 when it's finally being used. The rising impact of antimicrobial resistance will have an impact on our sepsis outcomes. We don't have a lot of new antibiotics. It could be potentially frightening if we don't get the right antibiotics there. Antimicrobial stewardship, thoughtful use of anaerobic antibiotics, beta-lactams may reduce both the rates and the outcomes from those. And even patients not admitted to the ICU have life-changing impact when they get sepsis. Machine learning sepsis needs to work, but alerts may in fact improve practice. And there's more to come about non-adrenergic vasopressors. And with that, I would thank you. And please come to Vancouver and visit us.
Thank you very much, Professor Allison. We usually leave the questions for the end of the session. Thank you very much. Allow me now to introduce Professor Arthur Slutsky, the person who introduced more than 750 original papers, 70 books, chapters, and many randomized controlled trials which have changed the clinical guidelines and practice. Professor Arthur's worked in University of Toronto. His researches were mainly focusing on made changes in the importance of athelectroma, discoveries of biotrauma, and the ventilator-induced pulmonary fibrosis. Give you the microphone. Thank you very much. Welcome, please, Professor Arthur.
So thank you very much. Thanks to the organizers for inviting me. My first time to Kuwait, and I have to congratulate Kuwait and Abdul Rahman. This is quite a conference. This is a world-class conference on critical care. It's really remarkable. And the other thing that's remarkable is the hospitality shown by the Kuwaitis that I've met. It's just been fantastic. So thank you very much. Really been a pleasure. So I'm going to talk about the year in review, talk about respiratory failure and ARDS. And what I did is I thought about what topics would be interesting, what studies might be interesting. So I've taken a few studies in different areas, some clinical trials, a couple clinical trials, some physiology, something about lung protective ventilation, and then something on artificial intelligence. In terms of conflict of interest, nothing here is relevant to my talk. As I said, what I'm going to do is first talk about definition of ARDS. There's a new definition, some lung protective ventilation, and a few other things. But I'd like to dedicate this talk, in fact, we're talking about ARDS and ARF, really dedicate this to Luciano Gattinoni, who was a friend and a colleague who died just 2 months ago. Very unfortunate. He had major contributions to this field and major contributions in sort of pulmonary physiology and ECMO and prone position and mechanical power and in many ways. So if we're talking about 2024, probably the major event was Luciano dying. And as you can see, he was a very eclectic individual, Renaissance man who was a great scientist, but also played musical instruments and had a band that did very well. So let me first start with the new global definition of ARDS. There have been many definitions of ARDS, as you know, since 1967. They're all pretty bad, including this one. Still we have a problem, and similar, I think, to sepsis. But what the new global definition built on the Berlin definition from 2012 and made a few changes that I think are interesting. So first of all, divided ARDS really, if you like, into three groups. One is sort of typical Berlin definition ARDS, intubated patients. Very similar, not really much of a change. But what it did add, and this was one of the major reasons that this new definition came about, was considered non-intubated ARDS. In other words, why should whether a patient is intubated or not decide whether you have a definition of ARDS or not? And so this, I think, is important with the increased use of high-flow nasal oxygen, that it's really important, especially you think about during COVID, how often high-flow nasal oxygen was used. So that's a new category, that's non-intubated ARDS. And the other is ARDS in resource-limited settings. And here what the definition said, well, you can also use SF ratio, saturation divided by FiO2, as well as ultrasound to make the diagnosis if you need to. So I think we have to, when we think about the implications of this, for today, current practice, absolutely no implications at all. When you see your next patient tomorrow at the bedside, this new definition doesn't matter. For research, it does have implications. Potentially identify cases earlier. So in terms of clinical trials, et cetera, we could potentially get earlier patients. When you're reading papers on ARDS in the next few years, it's important to think about which category, because as someone said a little earlier today, there's going to be a difference in mortality between those who are non-intubated and intubated. We're going to have to keep that in mind. And we have to understand the consequences of broadening the definition or allowing ultrasound and saturation. And as I said, I think the problem is that it is a syndrome like sepsis, and we need something in the future to maybe focus on treatable traits. We have to have a better way of identifying patients. I would hope that in 10 or 15 years, ARDS is sort of an anachronism from old times, that we have a way of classifying these patients with acute respiratory failure in which it directs therapy. We don't have that as yet. So now let's talk about lung protective ventilation. And I chose a trial here, a couple trials here. One trial was from Luciana Masha, looking at lung protective ventilation in patients with severe acute brain injury. And the hypothesis or the objective was to see whether the ventilation or lung protective ventilation in these patients would be beneficial or not. And she did a multi-center trial in 190 patients. Unfortunately, the study was stopped early because they had trouble accruing patients. And the primary outcome was composite of death, ventilator dependency, and ARDS day 28. So here are the results. And you can see it looks very promising. There's a difference in the Kaplan-Meier curves between the two treatments. Unfortunately, the conventional ventilation arm actually did better than the lung protective arm. And that's why I'm showing this study, really, because it's a bit unusual. Usually in most studies, the lung protective arm is better. Here it's not, and it's worth thinking about why that is. That may relate to the fact that the patients in the lung protective arm had a little bit higher PEEP. They had a little bit higher PCO2, all things that, as we know, might impact patients with brain injury. But still, it's worthwhile thinking about, when we're thinking about lung protective, or thinking about anything in medicine, think about, you have to look at specific patient groups because the implications may be very, very different. There's another interesting study that was not a randomized controlled trial, looking at the association between driving pressure and age. And the rationale was that aging affects the cardiorespiratory system, affects mechanics. And so what they did was an analysis of patient-level data from 7 large trials, total of 4,500 patients, roughly. And the main finding was that there was a large impact of age. If you look at on the left, that's the Kaplan-Meier curves. For patients less than 65 years old, it looked like driving pressure had no impact. High and low driving pressure, that's driving pressure greater than or lower than 11. For 65 to 79 years old, it had an impact, it was significant. And for greater than 80, it had an even bigger impact. So this was quite interesting to look at the age distribution. So what are the implications of this? Well, a lot of our patients, certainly in North America, are greater than 80 years old. Roughly 25, a quarter of the patients are over 80. And as I mentioned, aging impacts the respiratory system mechanics. So there's some interesting questions about why this result occurred. Was it related to inflammatory differences in these patients and other things as well? The bottom line at the bedside, if we think about personalized ventilation, so maybe we should be targeting driving pressure even more in older patients and maybe not using it so much in younger patients. So this article came out just a couple of months ago in the Blue Journal. I think it was quite interesting, quite thought-provoking. I want to switch now to high-flow nasal oxygen, which has been used for a number of years now, following the study by Fratt and colleagues in the New England Journal of Medicine. This is a study published in JAMA just 2 months ago in December. And the objective here was to see whether non-invasive or high-flow nasal oxygen was inferior to non-invasive ventilation in patients with acute respiratory failure. So this is a randomized controlled trial, a non-inferiority trial, in which they looked at 5 patient subgroups, which I'll show you on the next slide. They were randomized to either non-invasive ventilation, you can see almost 900 patients, or high-flow nasal oxygen, 900 patients. The primary outcome was endotracheal intubation or death within 7 days. And I put a little bit of the statistics in here. I'm sure that people's eyes glaze over, but it's actually very important to thinking when we're analyzing the study. They used a Bayesian hierarchical model, and they used dynamic borrowing across groups. That means they used data from one group to inform other groups using this Bayesian analysis, and that will become important. And the non-inferior odds ratio they used was less than 1.55. And that's pretty high. That'll become important again as I show you the results. So here's the enrollment in randomization. They started with 2,700 patients, excluded 900. You can see they had non-immunocompromised patients, immunocompromised, COPD, ACPE, and hypoxemic COVID-19 patients. And the first thing you can note is that the number of patients of non-immunocompromised and hypoxic patients, COVID patients, was quite high, but the other three groups were very small. So what were the results? Well, here's the primary outcome. This is based on the primary analysis on the Bayesian hierarchical modeling with dynamic borrowing. And you can see this looks like non-inferiority for all those groups. Look at them. Very, very tight. I don't have a pointer here, but very tight around the common line. It looks like you can use either, and that high-flow nasal oxygen appears to be non-inferiority. If you look at this, right? Well, they did a secondary analysis, a post-hoc analysis. They used the same Bayesian model, but they didn't allow the borrowing. And you can see here, the results are dramatically different. Dramatically different. And I think it gets to the point, I'm not a biostatistician, but I think to use borrowing like it is, the group should be very similar in their approach. There can be some heterogeneity, but they're very similar. And I think what this is showing is that they're quite very different. The other thing that this shows, if you look here, is the sample size in these three groups in the middle were very small. If you look at the acute cardiogenic pulmonary edema, the sample size doesn't look that small. 136 in each group seems, a reasonable size. But really what's important in terms of sample size is the event rate. And the event rates here are extremely small. In immunocompromised, 16 patients and 8 patients had the primary event. In COPD, 10 patients and 11 patients. So really this was markedly underpowered. The study was markedly underpowered, although it seemed to have a relatively large number of patients. So how do we, and in fact, when you look at the hypoxemic patient, I want to point out another point here. Look at the mortality. In the high-flow nasal oxygen, the mortality was 51.3% versus 47%. So if you look then, that's a difference of about 4%, and it looked like high-flow nasal oxygen was non-inferior. But that's a pretty big difference in mortality. So how do we think about this study? Well, I've talked about the heterogeneity of patient populations. In this patient groups in this study seemed quite dramatic, actually. There were reasonable sample sizes for a couple of the groups, but very, very small for the other groups. Importantly, the study didn't report on patient comfort, and one reason to use high-flow nasal oxygen is because of patient comfort. You think maybe it'd be more comfortable than non-invasive ventilation. So that's all problems. There's also, I think, a major problem with the statistical design within dynamic borrowing. If you just look at the eyeball test, you look at the results, you can see something is different with the immunocompromised and COPD. And there's a question, again, of whether the model, the assumptions underlying the model are valid. And the non-inferiority margin of 1.55 apparently represents a 10% absolute difference. So are we happy, would we be happy if there was a 5% difference between non-invasive ventilation and high-flow nasal oxygen, say, yes, it's non-inferior? Well, I don't think we would be. So I think the study was highly underpowered, unfortunately. Now, what are some of the mechanisms, because high-flow nasal oxygen is used a lot, but what are some of the mechanisms by which it's effective? And we know there's a number of mechanisms, including essentially increased pressure in the airway, washout of the airways, but there's some other interesting ideas that have come up recently. This is a study published, actually just in press, so it hasn't officially come out, in which they took patients who were orally intubated and then did high-flow nasal oxygen through the nose. So obviously it has no effect on gas exchange at all, because all it's doing is washing air through the nose. None gets into the lung. And you can see here on the left is a degree of dyspnea. And look at the red there, that's spontaneously breathing. And you can see that the patients on zero nasal airflow had a level of dyspnea. When the high flow was turned on to 50 liters a minute, the dyspnea decreased. And that was associated with a decrease in P1, or drive to breathe, also statistically significant. But remember, all they've done is flown gas through the nose. So it tells us there's something else about high flow nasal oxygen, either triggering receptors. And this group also had done another interesting study that was also in press in the European Respiratory Journal. And here they looked at various interventions that might relieve dyspnea in critically ill mechanically ventilated patients. So they took patients who were on pressure support, they increased the pressure support level, and the degree of dyspnea decreased. Not really a surprise, that's great. But what they did also was they blew air on the leg of the patient. You wouldn't expect that to have an effect on dyspnea, and it didn't. But they blew air on the face of the patient, and that decreased the dyspnea level. When they played music, pink noise was just noise, had no effect on dyspnea. When they played relaxing music, the degree of dyspnea decreased. I think this is important. It's interesting because it's another mechanism which I hadn't really thought about, that we might decrease dyspnea. And dyspnea is pretty important because if you look at development of PTSD in patients who are in the ICU, having severe dyspnea is one of the factors that's associated with increased PTSD. So maybe a simple thing like blowing air on the face or playing the right music might decrease the level of dyspnea, and therefore might be something we might want to consider going forward. The final study I want to talk about has to do with machine learning. There's been a lot of talk about artificial intelligence at this meeting and many meetings, and SP2 targets. And I think this is a fascinating article published in JAMA a number of months ago in 2024. You know, there have been a number of randomized controlled trials that have looked at oxygen targets. Is it better to have an oxygen target with a relatively high saturation or a relatively low saturation of, let's say, 90 to 92? And these trials have been done and have largely been negative. So the trials have been negative. So what these authors did, Boole and colleagues, they took two big studies, the SPO2, the pilot trial and the ICU Rex trial, and I'll show you those trials. These are the two studies they used. The first trial had about 2,500 patients, the other trial had 1,000 patients. And they used machine learning approaches in the first trial, in the pilot trial, and developed a model, said what characteristics of each patient, now at an individual level, would predict whether they might respond and do better with high saturation or do better with low saturation. And they then took that model and then applied it to the patients in the second group, in the ICU ROC study, and they said, well, if these patients if we used the model that developed the first one, how would they have done? So I think a nice study because it's an independent validation group based on this. And what they found was pretty remarkable. They divided patients into tertiles, into 3 groups. And here's the full almost 1,000 patients. And this is the predicted individualized treatment response. So for that individual patient, what's the likelihood that they're going to do better in the bottom third with a lower oxygen target? And you can see that some patients had potential improvements predicted of 30%, or on the far right, favors higher saturation target, and some patients, again, had about a 30% predicted improvement. And what they found was, shown here, this is the tertiles now. So in the lower third, if those patients had been allocated to lower oxygen saturation, there would have been a 6% absolute reduction in mortality. Patients on the right, if they'd been allocated to higher oxygen saturation, there would have been about a 12% improvement in mortality. So, and for the whole study, the absolute mortality reduction in this validation cohort would have been about 6% lower if the patients had been treated with the right SpO2 target. Think about that, 6% absolute difference in mortality. That is incredible, that's phenomenal. That's really a phenomenal difference just by allocating the patients correctly. And what were the variables? This was interesting too. Here are the variables on the x-axis. There's about 11 variables. They start with the average treatment effect shown on the left, and there's individual treatment effect on the right when they add each variable. Most of the model was predicted by 6 variables, including mean arterial pressure, heart rate, age, PCO2, creatinine, and respiratory rate. That gave you most of the answers, simple things to measure at the bedside. So how do we interpret this result? Well, when we look at almost all RCTs now, or in the past 50 years, generate an average effect, not an individual effect. Of course, what we'd love to know is the patient we're treating is an individual patient. How can we treat them? Well, obviously, a randomized control can't do that because it would have to have 2 identical patients, one treated with the whatever therapy and the other not treated with that therapy. Can't really do that. And those are used by most guidelines. Now, there's been an increased focus over the past 10 years, roughly, on heterogeneity of treatment effect to look at trials. Most of them suggest you should use risk models, like what's the risk of developing sort of a disease or whatever. This one used an effect model, so it was a bit unusual in that regard. And usually most of the studies, most of the aficionados of these approaches using HTE suggest you shouldn't look at negative trials. You could look at positive trials to see which patients are most likely to benefit. This one used 2 negative trials, which is very interesting. And the effect model usually tends to overfit data, as pointed out by Derek Angus in an accompanying editorial. So the magnitude of the heterogeneity may have been exaggerated. He said the likelihood of overfitting is decreased, but not eliminated by using separate validation cohort. I'm not sure about that in a way. I mean, if it's a separate cohort completely, you should get away from that, but there still could be some impact of this was a post hoc analysis. So what are the implications here? There's huge implications if the results are correct. Like just on measuring a few variables, can you imagine your patient comes in based on a few variables, you assign them to higher saturation target versus lower saturation target, and that can decrease mortality by 6%.
Sorry to interrupt you.
Your timing, sir. This is the last slide. This would be remarkable. And perhaps more importantly, there are implications for other positive and negative trials out there. There's lots of negative trials where we're sure there's an effect. If we use this kind of approach, maybe we can come back and see a lot of the therapies are useful. There's 2 trials undergoing with 50,000 patients that hopefully will help inform this. In conclusion then, I've talked about the new global definition, and we still need a better definition. We need a troponin of ARDS. Lung protective, not necessarily best for every disease, and high flow oxygen, we still, whether it's that versus non-invasive ventilation, for many patients, we still don't have an answer. And I think artificial intelligence is going to change the way we do things over the next 5 years, 10 years. It's going to be dramatic. Thank you very much.
Thank you. And this is my honor to introduce the next speaker, who is a well-known Professor Dr. Michael Pinsky, who is a professor of critical care medicine, bioengineer, cardiovascular disease, and anesthesiology at University of Pittsburgh, and who is going to share with us a very interesting lecture.
So I can start even though it's not there, but I hope they'll get the slides up. I'm supposed to talk about hemodynamic monitoring update and perspectives. And the bottom line is that there have been no new relevant monitoring devices that are used for hemodynamics that have been introduced in the last 2 years. What has happened in the last few years is clinical trials using hemodynamic monitoring defined targets in selected populations to improve outcome. And so what I'm going to do in this talk, assuming my slides work, I can see them here, by the way, is to show you, first of all, the hemodynamic data, and then to summarize the clinical trials. There are 2 position papers by the European Society of Intensive Care Medicine that are under review, one of which is almost published, that go into the latest positions on hemodynamic monitoring. And I will tell you, and I'm a member of those committees, none of our recommendations are materially different than what we previously said. So that what I'm going to show you is consistent with what will be published in this year. So let me start with, even though there's nothing here. Hopefully you'll get this running in a minute. Thank you. There are 3 books that I was honored to be the senior editor for on hemodynamic monitoring, which go into the physiologic basis for why we're doing the monitoring. The first one is called Hemodynamic Monitoring, and the other 2 editors are Jean-Louis Vincent and Jean-Louis Thibault, both of which will be at this meeting. The second book is called Functional Hemodynamic Monitoring. It's quite older. And sure, right here. Thank you. So there's a fundamental truth, and that is that no monitoring device, no matter how accurate or insightful its data, will ever improve patient outcomes unless coupled to a treatment, which itself improves outcomes. And thus, the way you should ask is not, do I need this monitor? It's what information do I need to guide therapy to improve outcomes in my patient? And if you understand that, then you can see how specific monitoring devices may be useful in specific situations. When the slides eventually come up, which I hope they do, one of the papers that we did write 3 years ago was called Effective Hemodynamic Monitoring. And that was an expert panel where we addressed the question, what hemodynamic monitoring guided therapies improved patient-centered outcomes? And we were able to demonstrate several large areas for which specific treatments work. And hopefully I'll be able to show those to you in a second. So the slides are really great, by the way. I'm sorry you can't see them. And hopefully this isn't going to take away from my time. Do you want to go to the other speaker, Wes, if he's ready, and then put this back on in a second when you get the technical system working?
In the meantime, I'm going to introduce Professor John Fraser. Dr. Fraser. Ely? Well, I want to introduce Professor Wesley Leslie, who is an internist and pulmonologist and critical care physician in Tulane University. Welcome, Doctor.
Thank you, sir. Okay, let's ad lib. My name is Wes Ely. Thank you so much for being here. And like the others, I'm just loving this time in Kuwait. I'm going to talk to you about the years in review related to sedation and delirium. And I'm going to start and end reminding us of what's going on at the bedside with our patients to frame this. So the first, it's the stuff of Stephen King novels, said Sarah Beth, nodding. I dreamed I was drowning, said Richard, in a font, a baptismal font, and they wouldn't let my head out of the water. The delirium stories flooded in. There were so many of them. One survivor on the Zoom screen had dreamed he'd been jailed for 5 years and his wife had died. The experience was so real for him that it took 2 years after surviving and getting out of the ICU to realize that it wasn't true, even though his wife was right there with him, day in and day out. If we can put in our minds the fact that we don't know what our patients are going through, the way that they suffer is so immense, and we only partially grasp how it is that they're suffering from this cognitive dissonance, this cognitive difficulty while they're during critical illness. And so, even if they don't show the slides, I'll be able to do it without slides. I'm going to review with you some key articles that over the years have built a framework for us to make decisions. I do not have any industry relationships that require disclosure from a funding perspective. I do have NIH and VA funding for about 30 years now. And if I tell any stories like the ones I just told, I have explicit written permission to talk about these patient stories, including their names and pictures. These are investigators whose data I'm going to show over the course of my talks today and tomorrow. All of these investigators, senior, like Pratik Pandarapandi in the top left. I don't know where the pointer is. Maybe it's, I can't tell. Or junior investigators like the guy in the bottom right with the fancy green bow tie. Which one's the pointer? Is it working? No. These investigators are all in our research center, the SIB Center, Critical Illness, Brain Dysfunction, and Survivorship. And they have done some remarkable work. Is it that one? What is it? Oh, I forget the point. I just won't use that. And they all echo this point, the investigations I'm going to show today. Thomas Paine wrote in 1776, "A long habit of not thinking a thing wrong gives it a superficial appearance of being right." We know that shock is wrong. We believe that somebody who with a mean arterial pressure in the low 50s is dangerous. And yet, this fact that the prevalence of delirium, acute brain dysfunction, is so rampant in the ICU, all of us, including myself, tend to overlook it and think, there's no way, if it's this common, that it could be that dangerous. So this young investigator, Justin Bannert, came to me and said, I want to go to lower middle income countries. Let's take Zambia and study and see, is delirium a big deal even in the non-tertiary care setting? And so he went to Zambia, and I went with him as well, and we studied over 700 patients in that area. Now, we were building on this original work by Pratik Pandarapandi, where he and I and other investigators proved that delirium was an independent predictor of long-term brain dysfunction. This is the study where we established in the New England Journal that people get out of the ICU, even 20-year-olds and 30-year-olds, with a degree of cognitive dysfunction that looks like dementia. And the main predictor of the fact that their brain doesn't work the way it used to when they get out is the duration of delirium. But we showed this in tertiary care settings in the United States, and what we wanted to know was, is it true in LMICs as well, across an entirely different spectrum of patients? And to do that, we went to Zambia, studied these 711 patients, and we also used the HUDAS and used cell phones to get 6-month cognitive outcomes, disability outcomes. In this study, whether it was 28-day mortality, 6-month mortality, or 6-month disability, we showed this remarkable dose response. If you look at the forest plot, 1 day versus 0, 2 days versus 0, and 3 days versus 0, you see this beautiful dose response where the point estimate gets further to the right if you have longer durations of delirium. In fact, in the multivariable analysis, where we adjusted for these 7 covariates, we saw this nice rise in hazard ratios. You go from 0 to 1 to 2 to 3 days of delirium. I frankly did not think we would see this. I thought, you know, these patients are on wards in Zambia, not even in an ICU, and look, it goes from a 6% increase to 1.79 to 3.42 in terms of 28-day mortality, 6-month, 1.43, 2.2, 3.92, and then 6-month disability, the same trend. And after adjusting for all these covariates, I really didn't think that delirium would be such a profound independent predictor. So now, across the globe in multiple different settings, we've seen that this organ dysfunction that arises acutely in critically ill patients is really too important to ignore. So the conclusions were that a simple tool, like the CAM ICU or this BCAM, which was invented by one of my colleagues in emergency medicine at Vanderbilt, takes less than 1 minute. Super easy at the bedside. And the third talk, the second talk tomorrow, I'm going to demonstrate how to do the CAM and the BCAM so that all of you, when you leave, will think, wow, that is not hard to do. I could do this at the bedside all day long and not get behind. I won't be late to clinic, and I'll get my notes done, and I'll still be able to identify this delirium. So what can we do about it? Is it about a drug? Tim Gerard, first author of this beautiful paper, and my mentee, when he still had hair on the top of his head, that is. Now he has it only on in his beautiful beard. He designed this study, which we published in the New England Journal, about antipsychotics. Can you give a drug to reduce delirium? And our hypothesis was that typical or atypical antipsychotics would do something to affect the duration and the consequences of delirium. You may not know this, but it was over 50 years ago, or right about 50 years ago, when this cigar-smoking Jesuit priest doctor from MGH wrote this article, Ned Kassem. People tell great stories about Dr. Kassem. And he hypothesized that Haldol would be good in cardiovascular ICU patients. And for 50 years, we've been doing this ever since his original paper. Well, we enrolled these hundreds of patients into this investigation with a broad stroke of diagnoses. The unifying theme here is that you had to be on a ventilator or in shock. So if somebody's in the ICU on mechanical ventilatory support, including BiPAP, or in shock, they got in this study. And when we randomized to placebo versus double-blind, placebo-controlled, either typical or atypical antipsychotics, nothing happened. All of us are, me at the bedside, nurse says, Miss Smith has delirium today. The CAM ICU is positive. I think, oh, good, let's write for a drug. And then I think, I've done something. Turns out I've done nothing. I haven't done anything to treat their delirium or their mortality. And although there are 2 papers, this is one of them, that hint at, in subgroup analyses, that Haldol may be related to survival, there are no clear data that the drug really does anything for delirium or survival. Anderson Ramberg here, I've spoken with her, excellent investigation to generate a hypothesis, but it did not prove that. In fact, the primary outcomes in the study were negative. So this is the last patient that we enrolled in our Mind USA study, which we published in the New England. And it reminds me, Wes, at the bedside, when your hand is on the shoulder of your patient, do not trick yourself, me, into thinking that you can write for a drug that will treat this. The brain dysfunction is about way more than any one drug. It's about, is their family there reorienting them? Did I get them out of bed today? Did I do an SAT-SPT combo and stop sedation and get them off the ventilator in a timely fashion? This multi-pronged approach, which we're willing to do for shock, by the way, we need to do for the brain. So the conclusion, whether it's Haldol or ziprasidone, we don't find any effect on outcomes. There is a hypothesis that has been generated in 2 papers about survival, but in the Anderson-Ramberg study, delirium wasn't even measured, so we don't know anything about that study having an effect on delirium. So how about sedation? Is sedation itself going to fix the delirium problem? This is my colleague Chris Hughes, also at Vanderbilt, and we published this study in the New England Journal called MENS 2, like Mending the Brain 2, MENS. And the hypothesis was, and get this is very important, this top bolded line, in septic, lightly sedated, ventilated adults, that pitting an alpha-2 agonist versus a GABAergic drug would make a difference. Because we had seen earlier in Pratik, when Pratik was young and my mentee, before he's now above me, he's my boss, lorazepam, clearly, long-acting benzos are independent predictors of transitioning patients into delirium. We're going to get back to this at the COVID pandemic in a minute. But we saw this steep rise with dose and the relationship with patients going into delirium years ago. And when we were using fairly heavy sedation, back in 2007, we saw a striking relationship between switching or randomizing to alpha-2 agonists, like dexmedetomidine, versus benzos. And you can see the black lines are lower across the board there, day 2, day 3, day 4, day 5. The black lines are much lower than the gray bars because they were on alpha-2 agonists and not GABAergic benzos. So in another intervention that we did a year after the MENS 2 study was this idea of, well, how about if we just stop sedation altogether? And so Tim Gerard in this ABC study, we showed that if you stop all of the sedatives every day in the ICU on a ventilator, and if they have to have the sedative turned back on, put it back on at half the dose. So you're ratcheting down. Stop, half dose. Stop, half dose. Stop, half dose. So you're ratcheting it down or you're stopping altogether and not restarting. When you cut the drugs, and this study found that when you cut propofol in half over the duration of the ICU stay, and narcotics, opiates in half, and benzos in half, that's what happened in this study. The intervention group, shown in the blue here, has a 15% absolute increase in survival, a number needed to treat of 7. So either in the older deep sedation days, either stopping them altogether or switching off of benzos works. Yahya Shahabi, who's here, did a beautiful job in his series of SPICE studies early here, showing that deep sedation in the dashed bar is a risk for death, increased death. So this is 2 studies in a row, the ABC study and Yahya SPICE study, that showed this relationship. This investigation, the MINS 2 study, so what we did was we randomized to Dex versus propofol, high-dose Dex, and then we had, the only person who knew what they were getting was the nurse, because when you unscrew the IV strip, you can see the propofol dripping out. So there's no way the nurse could be blinded because it's milk. But otherwise, everything, the tubing and the bag, were masked with grayed out opaque blinding tools. Chris here with the first patient enrolled in MINS 2, again, trying to get your mind back at the bedside, thinking this is about real people, real wives, real husbands that I'm talking about here, and no delta. In a light sedation strategy, when patients are about RASS 0 to -1, the propofol Dex question was totally neutral. No difference in outcomes whatsoever, whether it be time on the vent or mortality, which was really important for us to learn. These early signals we saw when we were heavily sedating patients, if you're lightly sedating your patients, it's not about the drug anymore. The delirium is not. Moving on to the last study, and I'm going to show you one more bonus study at the end real quickly. Brenda Punn, amazing nurse, CV better than most doctors I know, studied COVID-related delirium. We were getting all these emails from people around the world at the beginning of the pandemic, and they were saying, hey, wait a minute, the amount of delirium we have in COVID is out the roof. Let's study this. So we set up an investigation with the hypothesis that overuse of sedation and abandonment of proven guidelines would harm our patients. And that's what we did during COVID. And I mean, I'm guilty. All of us did it. We were afraid. We did not have PPE. We didn't have the vaccine yet. And it was a scary time, but we did some crazy things. And I don't want to live like that anymore as a doctor. We did this international study, over 2,000 patients, 14 countries, and it was prospective. We assessed delirium, coma, and risk factors. And the mean age was 64. They were very sick. Most of them were on a ventilator, and 80% of them coma, 55% delirium. So how were they being treated? The vast majority of them got either benzos, propofol, and a lower number of dexmedetomidine. They were not getting daily wake-ups in COVID. You know, I mean, I was there, you were there, we were outside the glass, and they were just we kept them snowed because we were afraid that they would self-extubate. We weren't in the room. How would we get in there quickly enough with all the PPE to re-intubate them? So frankly, we adopted a 1990s approach to medicine. And there was one day on rounds, I was sitting there thinking, God, I feel like I'm an intern again. This is the way we treated people back in 1990. I'm really old. You see all my gray hair. But we had gotten away from it for 15 years. All of a sudden, it was like deja vu back into a bad time. And what we found in this 2,000 patient investigation is highlighted in these 2 yellow lines. Basically, the drivers of delirium were overuse of sedatives and underuse of family. These were statistically, by multivariable analysis, the main things driving the brain dysfunction in these ICU patients. So in conclusion, delirium and coma in the pandemic became the epidemic within the pandemic. This double duration of delirium, of brain dysfunction, portends a big problem for their long-term outcomes. I don't have long-term outcomes from that study, but our SIB Center, Critical Illness Brain Dysfunction Survivorship Center, the S, we have huge support groups every day for our patients, in person and on Zoom, and we are filled up with a wait list of hundreds of people trying to get in because they say that their brain doesn't work anymore. They can't go back to work, they're retired, they can't manage their finances, nothing. It's super depressing for them, and most of these are COVID survivors. By the way, I was wrong about long COVID. At the beginning, I thought that long COVID was only PICS. And all these people were talking about their brain dysfunction after COVID, and I thought, this is stupid. This is PICS. We've known about it for 20 years. But then we had all these people coming to us saying, can I get in your survivorship support groups? I've got long COVID. I can't think anymore. And I said, well, how long were you in the ICU? Thinking, oh, I'm smart. I'll prove this was just PICS. They said, oh, no, I was never hospitalized. I mean, what? No, I was never hospitalized with my COVID. And I was fine. And 3 months after COVID, my brain went down. So I had to really learn a lot and eat humble pie and realize that there was a new disease state. Well, new. It's been around for 100 years, but it's a infection-associated chronic condition. It just happens that during COVID, we accumulated hundreds of thousands of people with an IACC, infection-associated chronic condition, called long COVID. So we're studying that now. And then my time is up, I think. I don't know. I'm not looking at the clock, but I bet it is. So the last thing I'm going to tell you about is just that we did and completed an INSPIRE study, thinking, well, maybe if we use inhaled isoflurane versus propofol, we can see a difference. And we're going to see the results in April. But in general, what we did here was we hypothesized that this inhaled isoflurane would be non-inferior to IV propofol. And frankly, I don't like the way we set it up because it was only a two-day delivery. We used a 3-in-1 device, an Sedaconda, and heat and moisturizer exchanger, evaporator rod, and then the device recollects the gas and redistributes it to the patient. I just want to tell you a quick story. First person I enrolled in this INSPIRE study. This guy has profound liver failure. Picture it. Icterus, bilirubin of 21, totally delirious, encephalopathic, whatever word you want to call it. Deeply sedated, RAS -4 at the time I saw him, but earlier very delirious and RAS -2. He's on the SIVA, he's on the ISO, and it came time to do an SAT. So we turned off the inhaled isoflurane. And now you think about if you had a person on sedation, RAS -4, liver failure, and you turned off sedation. They'd stay zonked for, 4 or 5 days? Wake up very slowly, metabolizing, gone from the liver. This guy woke up to a RAS 0 in 5 minutes. It was shocking. I have not seen anything like it in this particular clinical setting. That's an anecdote, but we studied it across the board in this investigation. Very big setup here. And the key was that the doctors got to set the targets. So we'd set a RAS target, and then we would do these daily wake-ups. And again, unfortunately, the way the FDA had it set up, we only had the drug delivered for 48 hours. So I don't think it'll have an effect on delirium duration or long cognitive dysfunction here, but we proved it was safe. And now we're going to design another study where they stay on the inhaled for the entire duration, which I think could separate the groups enough to make a difference. Hey, thanks a lot. Let me close with one more delirium story to get our heads around this, and then we'll move on. It's disquieting because you think the dreams are gone and your life will be normal again, but then they return and they remind you that it's not. You're right. It all came back to me one day, Kyle said. This man had had delirium in the ICU. He was young, and he was on the ventilator, and he says this: behind the monitor was a black jaguar perched up in the corner in pounce position, moving its tail real slow. I remember getting upset. Katie, my wife, thought it was just about the monitor and being hooked up and said, "It's okay, Kyle, it's helping you breathe." But I was thinking, there's an apex predator in the corner. Are we really going to pretend this cat isn't about to pounce on us and tear us apart? And when you talk to these people about these stories, it's amazing for me to think that as a doctor, I've been with these people at the bedside and so ignorant of what they're experiencing in real life. Let's do better. Thanks a lot.
Now we are ready for Dr. Pinsky. Apologize for the technical issues.
This is not the right lecture. This is my lecture from 3. I want the first lecture. They're listed 1, 2, and 3. I want the one numbered 1, called hemodynamic monitoring. Okay. Anyway, the point of it is that if you look at functional monitoring, which means that if you're going to do, I'm going to give you some relevant things right now. One of the things we developed years ago was a concept called functional hemodynamic monitoring, in which you use dynamic changes in physiologic variables to get more information out of the than you got originally. For example, if you were to do an electrocardiogram and it's normal in a patient, does that patient have coronary artery disease? You don't know. You might know if they've had a heart attack or an arrhythmia, but you don't know if they have coronary artery disease. But if you do the exact same ECG and put them on an exercise treadmill and get their heart rate up to about 80% of their maximum, and there's no ST segment depression or T-wave inversion, you can be very comfortable saying they do not have clinically significant coronary artery disease. It is the same ECG. I haven't changed it, but it's what I've done to the patient. So what we've been able to do is looking at the arterial pulse pressure variation and stroke volume variation during positive pressure breathing, or the change in cardiac output with passive leg raising, to identify if patients are volume responsive and what is their vasomotor tone. And those are called functional monitoring, and when we invented that term, I think it was 20 years ago, it is now the standard of care. So using functional monitoring, if my patient is in shock but they're not volume responsive, they should not be given fluids, because it will not increase cardiac output, it'll only volume overload them. And one of the first things we said in our very first paper in 1999 was that this system will limit the excessive use of fluids. Subsequently, several studies have shown that in septic shock in particular, using dynamic parameters prevented fluid resuscitation in non-volume responsive patients, and the amount of fluid accumulation in the group using dynamic parameters to guide resuscitation was less, and they had a better outcome. So that's one. Number two, how do you wean a person off norepinephrine if they have a normal blood pressure on norepinephrine? Well, what you do is you throw them in the water and see if they can swim. If they start to drown, you say, oh, that was a mistake, and you pull them out. You turn off the norepinephrine and you see if they become hypotensive, with all the negative things that hypotension will do to the human body. But if you looked at the pulse pressure variation to stroke volume variation ratio, a term which we call dynamic arterial elastance, in you and I, it's greater than 1. Pulse pressure is slightly higher than stroke volume variation because of the characteristics of the vasculature. If it's greater than 1 on positive pressure, at all, spontaneous breathing, positive pressure breathing, if the ratio of pulse pressure variation to stroke volume variation is greater than 1, you can cut the norepinephrine in half, and there'll be no drop in blood pressure. And when that was done in patients after vasoplegia to cardiac surgery, they got them off the vasopressor 6 hours earlier and shorter time in the hospital. So these are real approaches that have been applied in the operating room and the ICU and have improved outcome based on hemodynamic monitoring. Okay? And tomorrow, assuming my slides work then, I'm going to show you that you can do this system, which was open loop and used around the world, closed loop, to totally diagnose and treat cardiorespiratory insufficiency and fatal hemorrhagic shock without ever touching the patient. The machine will do it for you. And we did that as well. Let's see if this works. So one of the things I will tell you, because I can, is that when you're thinking about using hemodynamic monitoring, the question is, why are you monitoring the patient? And it'll be a different answer depending on where the patient is. If a person is in the emergency room, you want to make sure you don't miss anything, because you have no idea what's going on with the patient, and you're using it primarily for triage to identify if something bad is happening. If you're in the operating room, except with emergency surgery, the patient came in healthy, and you'll take zero tolerance with errors. So you want the monitoring to prevent any form of dysfunction, because the patient came in healthy, you want them to leave healthy. On the floor, if you're going to measure something, you want to make sure that if something happens and they go off the rails, an alarm goes off, but you don't want the alarms to go off too much, because that's just acoustic wallpaper. It makes the room sound like there's alarms and no one listens to it, and that causes alarm fatigue. And the ICU is somewhere in the middle. We want to have alarms. They can be inaccurate at certain times, but what we're still doing is the same. Is it working?
Yeah.
How about that? Thank you. These are my conflicts of interest. Not doing much now. I just have a whole bunch of NIH grants. Tomorrow, the patent we have at the University of Pittsburgh will be important. Okay? So I said to you before, no monitoring device improves outcome unless linked to a treatment. And my reference for you to use are these books, which are summaries. The best one is the latest one, Hemodynamic Monitoring, because it has all the physiology in it as well. So I recommend these to you. I do not get any royalties whatsoever for any of these books, and they're not that expensive. Okay. So in the emergency department, we read rapid triage. In the operating room, zero tolerance. In the ICU, somewhere in the middle. And the real battlefield for hemodynamic monitoring will be in the non-acute care settings. That's where we have to have it. Think for a second. Where are all the sick people? In the ICU. But where are the codes called? The cardiac arrests. They're on the floor. Wait a second, the sick people are in the ICU, but the codes are on the floor? That's because you didn't monitor them as they deteriorated. That is the battlefield we're going to be in the future, but we're not there now. So if we look at the principles of specialized, invasive, pre-op, operative, and how this level of severity, what we really have is we have a, sorry, gotta go back. We have a structure of monitoring which will be different depending on the environment. The mantra for you and everyone should be the following. You want your monitoring to be continuous, because if you're not monitoring and something happens, you missed it. To the extent possible, you want it non-invasive, because then you can put it on people quickly. And what you really care about is metabolism. I really don't care what the blood pressure is if the body's fine. And I really don't care what the blood pressure is if the body's terrible unless it's low. Okay? So, one of our original papers, Jean-Louis Touboul did it, was this ramp-up approach to management. You start off with non-invasive monitoring, and as the patient gets more and more unstable, you go to continuous, non-invasive, minimally invasive, and then finally, if you need to, significant arterial catheter, pulmonary catheter, transvenous. The causes of shock are multifactorial. They include hypovolemia, vasoplegia, and impaired ventricular function. But as far as you're concerned, all you care about is the fact that you want to give volume pressors and inotropes. Okay? So what you're focusing on is, what do I need to go up or down to stabilize the patient? And there are various things that we have, but what I want to focus on is blood pressure. If you're hypotensive, the body's ability to auto-regulate flow stops, because the input pressure for organ perfusion is arterial pressure. Arterial pressure is not tissue perfusion pressure. It is just the input pressure. Minus its critical closing pressure is the true tissue perfusion pressure, and that's going to be much less. In you or I, your arteries close down about 45 millimeters of mercury. If your mean arterial pressure is somewhere like 90, that means that you've got about a 40 millimeter mercury driving pressure for blood flow in your body. And that's true for your patient as well. Hypotension is always pathological. We can use beat-to-beat changes in pulse pressure to represent stroke volume, and that's very useful to assess volume responsiveness. But hypotension is relative. It doesn't matter if your mean arterial pressure is 80, 75, the mortality rate goes up in critically ill people, the lower the peak blood pressure is, and the longer that you stay hypotensive. So if you have a patient that's hypotensive, get them out of hypotensive fast. How do you do that? You might use volume, but if they're vasoplegic, they need norepinephrine. Okay. So the most common method that you use today in a non-invasive way to measure blood pressure is with an automated blood pressure cuff. Okay. And the way they work is they inflate and deflate, and they estimate the blood pressure. And nurses absolutely love this. because they just push a button and they get the blood pressure. The reality is that these devices are terribly inaccurate. And as you can see, you can be off by 20 to 30 millimeters of mercury up or down. And this has been known for a long time. So if you really want to know arterial pressure, you have to put in an arterial catheter, or you have to measure it yourself using a stethoscope and listening for the Sharofkoff sound. And they work, but you have to measure it, okay? So don't use automated blood pressure cuffs to titrate pressors in your patients if they need to be on pressors. So we had a position paper that we did in 2016, and the Critical European Society of Intensive Care Medicine. We have a new position paper that'll be out next year, this year, 2025, and the data and the recommendations are not any different. Basically, clinical assessment is one of the fundamental tools, and as Jean-Louis Vincent said earlier about sepsis, look at your patient. Understand what you're looking at. Assessing the patient at the bedside is the most thing. There's nothing I can give you that's as good as that. Echo is an excellent tool, and we should use it immediately, but it is not hemodynamic monitoring. It is intermittent at best, but it's phenomenal for separating out cardiogenic obstructive shock from all others. Central venous catheterization is useful because it allows you to infuse fluids and pressors quickly, and it also gives you the advantage of measuring CVP. And you and I, our CVPs are the same, and if we add up everyone in this room, we'd all have the same number, 0. A normal CVP is 0 to 1 or 2, max. If your CVP is 12, you are sick. And since CVP is the back pressure to venous return, if your CVP is 12, the pressure in the periphery is to be 24, which is going to cause a lot of edema. Okay. So CVP is important to assessing right ventricular function, and it's the back pressure to organ blood flow. The things that we can measure, independent of the arterial pressure if we have a central venous catheter, are the central venous O2, which is not that accurate, but arterial to venous CO2 is very accurate because CO2 diffuses rapidly in venous blood. So the arterial to venous CO2 in you or I, it's 4 to 5. If it's 6 or higher, you have decreased flow. That person's in shock, or they're exercising. So we said that you can measure SVO2, and it's useful in distributive shock. But more importantly is the delta PCO2 value. It's just a blood gas. If it's greater than 6, you either have a person who's exercising or they have decreased blood flow. Either they're making more CO2 or the flow out isn't good enough, and that is very specific. So if we move on further, arterial catheterization, there is no one blood pressure. What's the blood pressure here? Diastolic pressure is a function of vasomotor tone and heart rate. You can't see the HR there. So the group in Santiago, Chile did a large study called Andromeda in which they targeted resuscitation, but they looked at it retrospectively, and this is Espina's work with Jean-Louis Thibault, and he'll be talking about this greater tomorrow. But what they did is they looked at, in the retrospective data on the left side, the ratio of heart rate to diastolic pressure. If it was greater than 2, as you can see on this line here, mortality by quintiles went up. And this was true for the whole group. But look at this. If they looked at the entire group and for the constant heart rate, and they only said, what is the diastolic pressure? The lower the diastolic pressure, as you can see in quartile 1 and 2, the higher the mortality. But watch, if you only looked at the heart rate, for the same diastolic pressure, if the heart rate is higher, you have a higher mortality. That is Michael Pinsky's rule number 1. Tachycardia is never a good thing. It may be necessary to stay alive, but it masks hypotension, and it's a measure of stress. Okay? So if we were to look at dynamic parameters, let's assume I have a big heart and a not so good heart, and I were to vary venous return, which happens with positive pressure breathing, I would see that both of these hearts would have a stroke volume variation. Eventually, I'll lose that stroke volume variation. So it doesn't matter where I am. If I've got a stroke volume variation with positive pressure breathing above maybe 10% or so, I'm volume responsive. And the relationship between stroke volume and arterial pulse pressure is linear. So I can measure pulse pressure on anyone. So based on that, Paul Merrick and others have shown that pulse pressure and stroke volume variation are some of the most accurate ways of identifying volume responsiveness. It has a few false negatives, but as Sheila Maestra showed in this very nice study, I think I pronounced your name, by the way, Sheila, I'm sorry. If you simply take a person who's on 6 mLs per kilogram tidal volume and you go up to 8, and you simply look at the change in pulse pressure variation over just 30 seconds and put them back to 6 mLs, you will see that you have an excellent predictive value of volume responsiveness. Stroke volume variation is good too, but I don't need it. I just need an arterial catheter. I don't need any fancy devices. And in summary with Xavier Monet and Malou Melbran, we showed in this summary paper that there are multiple ways of assessing volume responsiveness that you can use. And I am sure that you have in your ICU right now one of these devices. You don't need to buy a thing. Just use them, and the managed number is a pulse pressure variation or stroke volume variation greater than about 10, or change in cardiac output with passive leg raising of about 10%. Is that important? Yes, because as the Andromeda study showed, within 1 hour of resuscitation, most patients here in orange are no longer volume responsive, even though they came in septic. So if you don't constantly reassess their volume responsiveness, you cannot understand that they don't need any more volume. Furthermore, even if they're volume responsive, they may be at risk for fluid overload, even if they're volume responsive and in shock. So you have to be intelligent. Intracranial pressure, intra-abdominal hypertension may limit the amount of fluids you give to a patient, even though they're volume responsive. So you have to balance the fact that fluid is a drug. So we had this paper with a bunch of experts, as you can see, some very smart people, in which we said, what is effective hemodynamic monitoring? And it has to do with where you do it. For example, ECG monitoring increases morbidity in non-cardiac cases because you will see arrhythmias that have nothing to do with anything in them, and it's bad. But in patients with cardiac disease, ECG monitoring saves lives. So the same ECG in a different population won't be good. And this is not a minor point. So you have to be patient selective in what you monitor, because if you're going in a group that has very low incidences of complications, your device is going to cause more errors than it will help. Where we found it worked the best was pre-optimization of high-risk surgical groups, monitoring response to therapy, and preventing over-resuscitation, and AI features. So this is the table from our paper, and you can see listed here the various treatments that worked. And I'm just going to finish by showing you some of the meta-analysis of the data that showed that if you do guided therapy in high-risk patients and use featurization to prevent fluid resuscitation in non-fluid responsive patients, you'll increase survival. Okay. This is the goal-directed therapy in clinical trials, and as you can see from Pierce, it improves outcome if you give it early. And in fact, this was nicely shown by Gao. Treatments in which therapy was given before the development of organ injury improve outcome, but if you do it after 24 hours, it doesn't work. So patients transferred into your hospital after being sick for a day in another ICU probably don't need pre-optimization. There's our study from Pittsburgh process. And the same is true for the use of surgical patients. These are the data from Binez, once again. And finally, the dynamic parameters in sepsis showed here from a Canadian analysis. What they said was that these dynamic parameters prevented over-resuscitation and improved survival. And this is also true if you're looking at acute kidney injury. The same thing is seen here. There's improved survival. Why is that? Because you're not giving fluids to a body. The body cannot tolerate venous hypertension. You have no mechanisms in your body to prevent the damage from venous hypertension. And in encapsulated organs like the kidney and the liver, the intracapsular pressure can be very high and it causes acute kidney failure. So the number of papers that have come out recently in support of what I've just said are really just re-underscoring what I just showed. You give personalized care, do not give fluids to patients who are not volume responsive, get the blood pressure up quickly, and they will have decreased mortality, period. So final things you can do is if they're not volume responsive, you have to consider what to do. But in most patients, you give fluids, a little bit of pressors, they get better, everyone smiles and gets a cup of coffee. But in about a quarter of the patients, they stay vasoplegic. They aren't doing well. And for them, you have to go with advanced monitoring to determine, is there cardiac dysfunction? Is there capillary leak in the lungs, etc.? And we suggested that in patients with severe shock who are not responsive to therapy, especially if they have ARDS, giving fluids can make them worse. And for them, we recommend the use of transpulmonary thermodilution or a pulmonary artery catheter. It seems unreasonable to not use these devices if your patient is sick and you're worried about the risks. Bedside echo is extremely good, but it is not a monitoring device. It is a way of stratifying patients. So in summary, this was a lot, but I didn't think my time was there because it took forever to get up here. Hemodynamic monitoring has many clinical uses. It defines cardiovascular states, and it's excellent as an early warning system. Specifically, it allows you to do goal-directed therapy and prevent fluid resuscitation if they're not responsive. The approach should be, in terms of monitoring, ramp up the degree of invasiveness and accuracy if the patient's care is unstable and they need it, and if not, you can stay with less invasive, because the more invasive you go, the higher the complication rates. Targeting fluid resuscitation based on fluid responsiveness decreases fluid administration, has good short-term outcomes. And with that, I thank you for your attention.
Thank you very much again, Professor. I'm sorry for this mishap.
I didn't realize it would be this hard to give a talk.
Well, once upon a time, you have to experience. Thank you very much. Now let me introduce Professor John Fraser, the founder and director of the Critical Care Research Group in Australia. Professor is the director of Intensive Care Unit at St. Andrew's War Memorial Hospital, founder and chief medical officer of Day1 Cordis, right? Yes, he is always proud of saying, I'm a father of great children, 5 great children. We are also proud fathers. Professor Fraser have almost published more than 700 publications and has received more than 120 million Australian dollar in 2018, I think, in competitive grants. Please let us enjoy your presentation. Thank you very much.
Thank you. Assalamu alaikum and shukran wafi to the beautiful people of Balil, Kuwait. It is wonderful to be back in this wonderful country. I've been watching the people struggling with the slides, and I've been saying to some of my colleagues, it's my 3rd time back in this beautiful country. And I've said, look, if my slides don't work, I'm just going to sing a song. And the people that know me know fine well that I will sing a song. So, alhamdulillah, the slides are up and there's no singing. So let's progress. I also apologize. I know that it's break time and prayer time. So please, if you want to leave, feel free to do so. I'll pass you back the microphone. So I'm going to try and stick briefly to the 2024. It's wonderful to have had my great mentor and friend Art Slutsky and Dr. Pinsky also I've learned from in the years. Just going to talk a little bit about what's happened and keep it narrowed down just because it is lunchtime and I apologise. I do have some conflicts that are moderately relevant. I was co-founder of Bivacor. We'll talk a little bit about that. And we've got some grants we're doing in pulsatile ECMO. I've just taken over as chair as the Global ECMONet from Art Slutsky and Dan Brody. So, your speaker said, I've got 5 children. I don't know how to say this in Arabic, but every trap, are we there yet, Mum? Are we there yet, Dad? And we could say the same thing for cardiogenic shock, because realistically, we haven't changed the outcome in cardiogenic shock in over 50 years. And one of the things I'd like to talk about is why is that? We've got all these fantastic, clever people like Dr. Pinsky and Professor Slutsky. They've been doing this for years. We've got fantastic hemodynamic monitoring. Hasn't really changed that much. Surely we can do a little bit better than this. We understand what cardiogenic shock is. It's an inadequate cardiac output, and it happens with 8% of people with infarcts. But the mortality really is unchanged. So we have to get back, and again, Art Slutsky talked about it, and some of the work Caroline Calfee's done, and ourselves have done, and endotypes and phenotypes. We have to get back to mechanism, because Einstein says the true definition of madness is doing the same thing over and over again and expecting a different results. And I put it to you that we're still doing that. So I'm going to go through what's happened in 2024 and perhaps some of the things that, inshallah, will make a difference in 25, 26, or 34. So the pathophysiology for cardiogenic shock, we've always kind of seen it as this. The heart becomes dysfunctional, cardiac output goes down, and we start seeing hypoperfusion. But more and more, we're starting to understand the idea that the systemic inflammatory response doesn't just happen in sepsis, but there's an inflammatory component in cardiogenic shock. And perhaps we're not addressing this at the microcirculatory level. And we know that as the progression happens, the heart becomes more and more dysfunctional, that the compensatory mechanisms happen. The vasoconstriction happens in some of the patients, but not all of the patients. The afterload increases in the sick heart, and therefore you get myocardial ischemia. But we have to believe that the inflammatory excess is changing more and more, because this is what we talked about, the paradigm, the classic paradigm, infarct to whatever cause, contractility goes down, organ perfusion worsens, you get vasoconstriction, as I've said, and you get ischemia, and eventually multi-organ failure and death. But we're understanding more and more, and there's I'm not going to go through every paper, but there's a large number of papers showing that the inflammatory state is a big, big component. And that inflammatory state, yes, happens at the macrocirculation, and we talked about how to do blood pressure, but it also happens at the microcirculation, and unfortunately, we're really not very good at looking at that. The second thing with cardiogenic shock is, are we comparing apples with apples? Because if we look at the different studies, and again, going back to what Art was talking about in the ARDS, we have to understand that if we want to try something out, we have to be looking at the same thing. And I don't think we are. If we look at a number of the different studies, the shock trial, we've talked about, heard about it this morning, these were the criteria for the shock trial. The shock 2 trial, 13 years later, these were the criteria here, different enough. The PCI trial and the heart failure guideline trial. So year after year, we change the definition, and it is difficult, therefore, for us to say we have to have a study definition that we all accept. Otherwise, we're comparing apples with oranges, and if we don't compare the same thing, how do we expect to see whether there is a subtle difference? And that's the NIH study in 2018. So can we unify? Can we come together and come out with criteria whereby, and again, Art said, you know, there's many ARDS definitions and they're still maybe not perfect. But this is the question that came out in, okay, it's not 24, but it's almost 24. The definitions towards unification of a comprehensive definition, and these are the criteria here. This is to be used in studies and registries. There's pragmatic definitions where this is what we're using at the bedside, and perhaps we don't have all the modalities. But there's also the recognition And we heard from Wes Eli earlier on, we've got hypoactive delirium and hyperactive delirium. Perhaps the normal tensive subtype in cardiogenic shock also happens where there is evidence of hypoperfusion, but the blood pressure is not below that 90 millimeter MAC. They're not on inotropes, they're not on vasopressors. So perhaps these things are not mandatory, and we will pick up more patients that are developing shock. Again, just at the end, just sneaks into the definition. The severity assessment is also important. If we're going to do studies with new modalities, we need to understand which patients are which. And this you'll start to see more and more from the at-risk, beginning, classic, deteriorating, and extremis. Because if we're counting patients from the extremis category and the beginning category, we're clearly not comparing apples with apples. The etiology is also important. When we used to look at ARDS and you'd have respiratory ARDS and non-respiratory ARDS, we realized there was a huge difference. But again, in these patient populations with cardiogenic shock, a patient who's had an infarct in the past and then has a chronic infarct versus someone that's taken an overdose of amlodipine or beta blockers, by criteria, they may both have cardiogenic shock. But it isn't too surprising that their outcomes are totally different. Post-cardiotomy is an acute phase, and once they get over the shock stage acutely, they may well get better. And then obviously the non-myocardial causes, in the same way with ARDS, the non-pulmonary causes, non-myocardial causes are different again. So the etiology has to be borne in mind if we're going to look at this properly. And we have to look at the etiology, the timing, the area of the myocardium that is damaged. An infarct of the full left ventricular wall is going to be very, very different from a right ventricular infarct. Entirely different ways that the left ventricle and the right ventricle work. We talk about cardiovascular, we a lot talk about just the cardio, but the vascular is just as an important component, and we have the classic, the vasodilatory, or the normal tensive euvolemic patient. And then there's other different types. So this is coming more and more into the literature. And it sounds a little bit academic, but this is a paper, and it's a little bit older than 24, but it's European Heart Journal. I think it's important to look at the different types of phenotypes. So wet and dry versus cold and warm. And we've all seen these types of patients, but they all fit into cardiogenic shock. But in this paper, they've done a nice job. I'm not sure that's working. If we look at the data over here, we can see that the difference is whether you're cold and wet or warm and dry, the mortality differences are substantial. So forget what treatment you're using. The fact that these have different phenotypes of cardiogenic shock has entirely different outcomes. So if we put these people all as a hodgepodge, the apples and the oranges are mixing up. One of the factors that we're very interested in is looking at the microcirculation, because when we move from the inflammation that people are seeing in cardiogenic shock, this is one of the areas that determines whether you're going to be fitting into the warm and the dry versus the cold and the wet. And what we're seeing in cardiogenic shock is there's more and more inflammation, and that inflammation changes your microvascular circulation. And there's nitric oxide changes, there's excess inflammation, microvascular thromboses, and closed capillaries, and this is what will eventually lead to microvascular collapse. And it's at the microvasculature that the mitochondria gets its oxygen. It's not in the macrovasculature. It's these small vessels that, again, we're not very looking at. But the problem is, once that microvasculature collapses, we are going to go into more organ failure. So trying to understand that is one component, and we need to understand the different types of phenotype as per that group. Pulmonary artery catheter usage has gone in and out of fashion more frequently than the jeans that I'm wearing today. They were in, they were out, they were in, they were out. It looks like there's some really interesting stuff on new right ventricular catheter, pulmonary artery catheter workload catheters that are happening just now. But we do need to understand the hemodynamics, and obviously if you've got an outstanding echo specialist in your unit, and I know some of the people in the audience do have, then that's fantastic, but not all of us have that. So perhaps the pulmonary artery catheter has got time to be reborn again to determine these shock phenotypes, because if we look at them, non-congested is best prognosis, cardiorenal intermediate, and cardiometabolic is worst. So again, early intervention is key to all of it. Going back to the previous slide I showed several slides ago, what is the etiology and how does it change it? Again, if we mix them up, if you look at the negative trials on the randomized control studies on acute myocardial infarcts and ECMO, that isn't the same as patients with cardiogenic shock without infarct. And in fact, if you look at the ECMO cardiogenic shock paper, 40% of those patients didn't have a myocardial ischemia problem. Same thing in staging. In the ECLS study, 50% of patients had severe shock stage 3, where the mortality was less than 15%. Hemodynamic targets, again, 2024 really hasn't changed anything there. Pharmacological interventions, we've talked about increasing myocardial oxygen utilization. There's very little new. There's been some meta-analyses, but very little new, I think, that's happened in this area. I've just put a number of the different studies that have been happening over the last little while, the DOREME trial, obviously, and the Optima. But realistically, we're still not seeing that any of the inotropes change any significant outcome. And again, this is, if people want to photograph, these are the data behind these different inotropes. It takes a long while to write these slides, but I don't think it's going to change anyone's difference, but feel free to change it. So we need to look at the risk-benefit ratio. Inotropes frequently will make patients feel better, but probably shorten their lifespan. That's that roughly summarized in one. So the traditional paradigms in cardiogenic shock are revascularize. If there's a hole that's blocked, unblock the hole. Hemodynamic correction, and Dr. Pinsky spoke about it, increase the cardiac output, but be aware that these cardiac output comes at a physiological cost with the arrhythmias, with the vasoconstriction, etc. And then looking at perfusion, the patient that comes in with acute pulmonary edema, the wet, cold shock patient we talked about. But now what's happening in the last year or two is more and more looking at intervening as quickly as possible to prevent progression and reduce this inflammatory excess. And again, without being too nice to Art Slutsky, it's a little bit like ARDS. Intervene as quickly as possible and break the shock spiral of cardiogenic shock. Look at it, whichever it's PACs or echoes if you've got that expertise. Reduce, not increase, the myocardial oxygen demand to reduce the risk of mitochondrial refunction. So we're not a cardiology audience, but we have to accept the data, and again, some of these are new data from 2024, from the culprit shock and the shock studies. Some of them are old. But what we are doing more and more, and it is problematic, we're using more and more mechanical support, but without very much data to support it. It's the balloon pump we've seen in the SHOCK 2 study. It doesn't improve outcome. In Impella, we're going to talk about the DANGER study, which came out. VA ECMO, I'm an ECMO advocate, but realistically our data saying that is changing things is very, very limited, and some other ventricular assist and total artificial heart. So we're increasing the use of these devices, but we haven't got better data. Again, is it because we're not understanding the mechanism, and do we have to look differently at things? So again, just to summarize, and we've managed to get some 23 and 24 papers in there for you. The balloon pump studies, that a long time ago, a lot of us still use them, myself included, despite the fact the data don't support it. The ECMO shock, cardiogenic shock studies, and more recently the DANGER shock study too. This is a slide that was put up by one of my very daring fellows, I think from the Pitié. He said, we know you believe in VA ECMO, Prof, but VA ECMO could stand for very appealing, but extremely complication-prone machine that does not improve outcomes. And this is a Lancet paper looking at an individual patient data meta-analysis. So even at the meta-analysis level, we're still not seeing any good data saying that in cardiogenic shock with an infarct, it improves outcome. So again, to summarize, most of the studies that have happened over the last while in mechanical support, so dark blue is cardiogenic shock and lighter blue is the EPR studies. And this is just from 2019. So it's a hugely busy field, and you'd have to think, especially as a zealot of ECMO, my goodness, why are we not getting an improved outcome here? But realistically, we don't have much to say that it's great. I mean, some of the studies are very, very small, but incredibly well conducted, really difficult patient groups. So this is what's up to the end of 23, and there's a whole pile, the Anchor, the Pioneer, the Verse, and the Unload ECMO studies. These are hopefully due in the next year or so that we're going to start seeing these data. So the one study we all clapped and raised our hand about was the Impella DANGER shock study, which looked at the microaxial flow pump, the Impella device with standard care. versus standard care alone. And the standard care alone, we're allowed to have crossover to have mechanical support. And for the first time, and it's about 180 patients per group, for the first time we actually saw a difference in outcome and a survival benefit, though there was a lot of significant increased risk of renal dysfunction and other important sequelae. But at last, we're starting to see in this very, very select group of patients with very specific hospitals that there was an improved outcome. So perhaps we've got some chance there. So trying to get you to your lunch, I think from mechanical, I think we've seen the inotropes. They're not really changing outcome. We've seen the fact that the phenotypes have to be understood. I would put to you, and where it's an area we're looking at genotypes and transcriptomics, we need to understand the different endotypes of cardiogenic shock to treat them better. But this, I think, is probably how we need to start looking at mechanical support. Compare the apples with apples, get the right patients into the study, look at the challenges with the patients, have a parachute to get them out of it. How can we do, is there equipoise? If there was a patient who was shocked, would you feel comfortable not putting them on an impeller or a VA ECMO? And we should. Other than the danger study, we don't really have an improved outcome. We need to understand that patients need to thrive, not just survive. Getting them out of hospital to die a sad, lonely death at home is not acceptable. We need to do better, and it's at a huge cost. And there's just too many complications. The patient, the pump, and the pathophysiology. It's as Art Slutsky said, we need to understand the mechanism. I think the mechanism is the microcirculation. It's the engine of multi-organ dysfunction. Whether it's the heart or the lungs, I think the microcirculation, we really need to understand more. It's the largest organ in the body. It's where oxygen is transferred across. It's regulated by a whole pile of different factors. And what happens in health is that macro and microcirculation are coupled beautifully, but we don't treat healthy people. We treat sick people, and that's where they uncouple, and there's a major problem. So in our engineering lab, and this is some of our work that was published within the last year, we took engineers to look at microvascular flow, and we took clinicians, so engineering lab and the animal lab, to look and see if we develop pulsatile ECMO, and we work with Xenios, but I've got no financial interest. We can look at the different timing. I'm not going to go through this because of time, but the timing of pulsatile ECMO, we think this is a big potential to reduce the workload and to improve the hemodynamic energy transfer into the blood. The problem is they happen at different times, and we're working on this over the next year or two. The Silver Heinz are doing this study, supported by the ECMONet. We did a randomized control study in the animal lab where we induced cardiogenic shock by injecting alcohol into the heart, so we could exactly get the degree of cardiogenic shock we wanted. We would titrate it. We would get an echo. This was the pre, and then this was the post, so we titrated a beautiful cardiogenic shock animal model. And then moving on to looking at the microvasculature, we could show that pulsatile VA ECMO in cardiogenic shock with an EF of 18 to 20 improved peripheral vascular density and improved the number of capillaries, optimized the oxygen consumption, induced more ATP production, reduced the amount of reactive oxygen species. And this is interesting in a 24-hour study, randomized control study, identical cardiogenic shock, continuous VA ECMO versus pulsed VA ECMO, and the pulse reduced the amount of inotropes required, very statistically significant. We're going to finish on this in terms of cardiogenic shock. I can say it's in the last year. Though it started with Daniel Timms in our labs in 2004. This is a Bivacor total artificial heart. So this is being used now. This is our animal lab in probably about 2016, I think. And this is one of our first animals where the heart had been totally removed and replaced by a total artificial heart with maglev that Daniel designed in his PhD and then brought to our lab. And this is a sheep with no myocardial tissue at all. And in 2024, and this is why I can justify including it, Daniel and his team did 5 successful implants of the Bivacor, removed the patient's heart entirely, and had a magnetic levitation total artificial heart, used initially as a bridge to transplant. But inshallah, if these all work, it will be used as destination. So mechanical support is coming. We're not good enough with it at the moment. We need to look at it more because more and more patients are getting cardiogenic shock. We need to support the other organs we've heard about. And where to next? Understand the phenotype and the genotype and transcriptome. Look at using deep learning. Look at prognosticating, understanding the microcirculation. Remember, our patients have got to thrive and not just survive. And this is just one little thing we've just got accepted today, the role of cardiac, microplastics in cardiac. So there's actually quite a lot of interest in microplastics. We can now see microplastics in the fetus and in the amniotic fluid, and we know that it causes obstruction of macro and microvasculature. So it's an interesting area, and we're going to have to be looking at it, because obviously our bypass and our ECMO membranes have got a huge amount of plastic. But with that, I say shukran wafi, and I think it's lunchtime. Thanks.
Thank you very much indeed, Professor Fraser. Thank you very much. I'm sorry to say we have to omit the questions now. It will be postponed for later. I've been recommended by the organizing committee to offer a compulsory tea break. So we need you all to go and have a tea outside, or coffee, or whatever you like to drink. And I think 12:10, we're coming back for the opening ceremony. Hope you enjoyed, and please enjoy the coffee and shake. Thank you very much. Thank you.